I'm Brandy. I'll be your nurse today, and I'm going to conduct a cardiovascular questionnaire in order to obtain your health history. What's your name?
Corvante McGregor.
Date of birth?
August 19th, 1995.
Okay, Corvante. Have you had any chest pain?
No.
If he would have stated that he had chest pain, we would then ask him, when did it start? How long have you had it this time? Had this type pain happen before, and how often? Then we would access the location. Where did the pain start? Does the pain radiate to any other spots? About the characteristic, we will ask, is it crushing, stabbing, burning, or vice-like? Is the pain brought on by activity? If so, what type? Rest, emotional upset, after eating, during sexual intercourse, or with cold weather? Do you have any associated symptoms with your chest pain? And if so, is it sweating, ashen gray or pale? Does your heart skip a beat, shortness of breath, nausea, vomiting, racing of heart? With the chest pain, is your pain made worse by moving the arms or neck, breathing, or lying flat? What relieves your pain? Okay, Corvante, any shortness of breath?
No.
If he would have stated yes, we would then ask him what type of activity and how much bring on the shortness of breath. The onset, does the shortness of breath come on unexpectedly? The duration, is it constant or does it come and go? Does it seem to be affected by position? Does the shortness of breath seem to affect you when you lie down or when you awaken from your sleep at night? Does the shortness of breath interfere with activities of daily living? Do you have to sleep on pillows at night?
No, ma'am.
Okay. If he would have stated that he sleep on pillows, we would then ask him, how many pillows are you sleeping on at night in order to prevent you from having shortness of breath? Do you have a cough?
No, ma'am.
Okay. If he would have said yes, we would then ask him, how long have you had the cough? Is it related to the time of day? What type of cough? Is it dry, a hoarse cough, a hacking cough, a barky cough, or does it sound congested? Do you cough up any mucus? If so, what's the color? Does it have an odor, or is it blood tinged? Is it associated with activity, positioning, lying down, anxiety, or talking? Does activity make it better or worse? Is it relieved by rest or medication? Do you seem to tire easily?
No.
The onset of the fatigue. When did the fatigue start? Was it sudden or gradual? Has any recent change occurred in the energy level? Is the fatigue related to the time of day? Is it all day? Is it morning or evening? Have you ever noticed facial skin turn blue or ashen?
No.
Okay. Have you noticed any edema in your lower extremities, like your legs and your feet?
No.
If he would have answered yes to the edema, we would then ask him, when did you first notice this? Any recent change? What time of day does the swelling occur? Do your shoes feel tight at the end of the day? How much swelling would you say there is? And if so, if both legs are equally swollen? Does the swelling go away with rest, elevation, after a night's sleep? Do you have any associated symptoms with the edema, such as shortness of breath? If so, does the shortness of breath occur before leg swelling or after? Do you waken at night with an urgent need to urinate?
No.
If he would have said yes, we would then say, how long has this been occurring? Any recent changes? Our next question is a cardiac history. Any past history of hypertension, elevated cholesterol or triglycerides, heart murmurs, congenital heart disease, rheumatic fever, or unexplained joint pain as a child or youth, recurrent tonsillitis or anemia?
No.
Have you ever had a heart disease?
No.
And he would have said yes, we would then ask him when. Do you know when the last time you had an echocardiogram?
No.
Have you ever had an echocardiogram?
No.
It's like an ultrasound of your heart.
No. Well, ma'am.
Your family cardiac history. Is anyone in your family history has ever been diagnosed with hypertension, obesity, diabetes, coronary artery disease, sudden death at a younger age?
Yes.
Okay. Who?
My great-grandmother.
Now we will ask you about your personal habits. What type of diet do you usually eat?
Kind of a healthy diet, but I get sidetracked sometimes. I eat junk food.
Okay. What's your usual weight?
195.
Okay. Any changes of your weight, like a fluctuation? Does it go up or down?
It fluctuates different ways, either up or down, depends.
Okay. Do you smoke?
No.
If he would have stated that he smoked, we would then ask him the age started, How many packs a day does he smoke? And have you ever tried to quit? Do you drink?
No, but I've tried.
Okay. If he would have said yes, he drinks, we would ask him how much, when was his last drink, and does he feel like he's an alcoholic? Exercise. Do you exercise?
Yes.
How many days a week?
5 days.
How many hours a day?
2 to 3 hours.
What type of exercise?
Running, strengthening, and that's about it.
Do you play sports?
Yes, ma'am.
What type of sports?
Baseball.
Are you on any drugs for antihypertensive, beta blockers, calcium channel blockers, digoxin, diuretics, aspirin, anticoagulants, over-the-counter, or street drugs?
No.
Okay. Covante, now this concludes our questionnaire, and next you will have your cardiovascular assessment.
My name is Shaquita Dixon, and I will be demonstrating a few basic techniques included in a cardiovascular examination. This video is intended to supplement your learning and should be used in conjunction with lectures and your reading assignments. You always want to stand at the right of the patient to facilitate hand placement, viewing of the neck veins, and auscultation of the precardium. Ensure that the room is warm and quiet. Shivering from a cold patient can interfere with heart sounds. Also, heart sounds are very soft and are masked by noise. Place the patient in a supine position with the head of the bed slightly elevated. I'm going to start by assessing his jugular venous pressure and carotid artery. Ask the patient to turn their head to the left. Identify where the external jugular vein is. It can be located by observing the internal jugular vein pulsation. The internal vein is deep, so you can not usually see it, but can see the pulsation. With this patient, the pulsation is observed above the substernal notch, which is the normal assessment finding for those who do not have jugular vein distension. Tangential light can be used to highlight the pulsations. The level of the pulses disappear as the head of the bed is elevated to a sitting position. Now I will assess his CVP, central venous pressure. Since his pulsations are just above the substernal notch, I'm going to use two tools, a straight edge in the form of a tongue blade, placed horizontally at the highest point of the pulsation. If the patient had JVD, you would use the highest level of the descended vein and place the ruler at the substernal notch and measure up. The measurement in this patient is 1.5 centimeters. Anything less than 3 centimeters is normal. Unilateral distension of the external jugular vein may be caused by an aneurysm. Full distension above 45 degrees is indicative of increased central venous pressure, as in heart failure. Next, the assessment of the cardiovascular pulse. Turn the patient's head straight. Palpate each carotid artery medial to the sternomastoid muscle in the neck. Avoid palpating in the higher area of the neck near the carotid sinuses. Massaging the carotid sinuses can cause a vagal response, resulting in the drop in pulse and blood pressure. Feel for the carotid in the lower half of the neck. You may need to displace the sternomastoid muscle in order to palpate. Assess both sides. Never palpate simultaneously. This can cut off the blood flow to the brain. When palpating, look and feel for amplitude and a brisk upstroke. Part of your assessment when you're palpating is to feel for thrills, which is sort of like a cat purring or a vibration. If you feel a thrill, then assess for bruits. Listen with both the bell and the diaphragm of the stethoscope. Listen to both sides. Auscultate in 3 areas: at the angle of the jaw, the mid-cervical area, and the base of the neck. Avoid compressing the artery, which could create an artificial bruit. Now we'll use the stethoscope to listen over the carotid for bruits, which is a swishing sound that indicates blood flow turbulence, usually related to atherosclerotic narrowing. This is important in someone who is middle-aged or older, that you may suspect cerebral vascular disease, and if you felt a thrill when assessed. An aortic murmur may radiate to the back of the neck and may be mistaken for a bruit. The next part of the assessment is focused on the precardium and the cardiac functions. Start by inspecting the chest, looking for any ventricular pulsations. Sometimes the point of maximum impulse, the PMI, may be visible on someone who does not have much musculature or someone who is very thin. In this case, I do not see it pulsating. Next, with the pads of my fingers, I am going to palpate in multiple areas, starting with the right sternal border at the second intercostal space. This is the aortic area. Moving over to the left sternal border at the second intercostal space, which is the pulmonic area. Now, on the left side, I'm going to move my fingers down to the third and the fourth and the fifth, which is the Erb's point, while feeling for thrills, heaves, and lifts, which are pulsations that may lift my fingers up. From the fifth intercostal space, I'm going to move my fingers laterally toward the midclavicular line, which is also the mitral valve area, and feel for the point of maximum impulse at the apex of the heart. Here you should feel the ventricular pulsations. Ask the patient to exhale and hold it. The pulsation of the heart should come up and tap your finger. If you can't feel it, have the patient roll to his left. This brings the impulse a little bit down. I am feeling once again for the impulse, and there it is. Percussion is used to outline the borders of the heart, but it has been replaced by chest X-ray and echocardiogram. Evidence shows that these are more accurate in detecting heart enlargement. Now I will auscultate over the same areas that I palpated over. I'm going to start with the diaphragm of the stethoscope and repeat the same motions with the bell in a rough Z pattern from the base of the heart across and down, then over to the apex. Starting at the second intercostal space on the right, moving to the second intercostal space on the left, down to Erb's point. Inch your way down with your stethoscope to the third, then the fourth and the fifth intercostal space. Now move over to the midclavicular line at the apex of the heart. Change to the bell and listen again in all areas. Note the rate and rhythm. Identify S1, S2. Listen for extra sounds, S3 and S4, and for a split S2. All the while, you are listening for murmurs. Some murmurs are common in healthy children and adolescents and are called innocent or functional murmurs, having no vascular or pathologic cause. A functional murmur occurs due to increased blood flow to the heart, usually caused by fever, anemia, or pregnancy. A normal split S2 is pronounced when the patient is inhaling. So if you have the patient take a deep breath, you might hear the split S2, which is the sound of the pulmonic and the aortic valves closing separately. Usually they close together, but because of the pressures in the lungs, when you take a deep breath, they will close slightly behind one another, and you will hear the two separate beats instead of one solid beat. I'm going to have the patient sit up and listen, paying special attention to Erb's point and the mitral area. Listen again for aortic insufficiency murmurs that may not be apparent when the patient is leaning forward.